Good afternoon, everybody. It's a pleasure to be with you today. Thanks to Professor Walid Osama who invited me to this meeting. As Professor Walid said, I will give a short presentation on how to use a tooth to save an eye. So before this, I would like to discuss the factors essential for cadaver corneal graft survival. You must have a normal lid anatomy and function, so normal blink mechanism, adequate stem cell supply, and adequate tear function. So we can summarize this as a wet blinking eye. If you don't have a wet blinking eye, then you cannot do the traditional cadaveric corneal grafts. In these cases, we do the keratoprosthesis. So the indications of keratoprosthesis is either the cornea and the ocular surface are not suitable for cadaveric tissues, there is a multiple field corneal grafts, bilateral end-stage corneal blindness, and you should have a healthy retina and optic nerve. Visual acuity should be PL with 4-quadrant projection, and the patient should be committed to regular follow-up schedule. To fix an artificial cornea, it probably would be either made of glass or plastic. This should be attached to the eye of the patient. So you should have a carrier for this plastic or glass lens. This carrier, we call it a skirt. So you can classify the keratoprosthesis either with a biological skirt or you use the corneal graft as a skirt. So if you use the corneal graft as a skirt, this is the famous Boston keratoprosthesis type 1 and type 2. Otherwise, you can use the bone as a skirt or the osteo-odonto or the dental lamina as a skirt, which is the osteo-odonto keratoprosthesis. So this is the Boston keratoprosthesis. You have the front foot plate, which is made of PMMA and is usually clear, and the back foot plate, which is made of titanium, and both plates there is a corneal graft in between this plate. So the corneal graft is sandwiched between the two plates, and you suture the corneal graft to the cornea of the patient. So here the corneal graft is the skirt or the carrier of the artificial cornea. So since you are using a corneal graft, the factor essential for a cadaveric corneal transplant should be present, which is the wet blinking eye. If you don't have a wet blinking eye, then this is not the ideal eye for Boston Cape Town. So this is some example of diseases which is not suitable for cadaveric corneal transplants. Stevens-Johnson syndrome, Sjögren syndrome, cicatricial pemphigoid, ectodermal hypoplasia, all these have severe dryness with keratinized surface and not suitable for cadaveric transplant. And please, if you find this patient, don't try any surgical modality of treatment, such as doing an amniotic membrane or doing a keratoplasty with amniotic membrane, because this will end in failure and the cornea will melt and probably the eye will be atrophic. The Boston team did another structure of the Boston keratoprosthesis, which is the Boston type 2. They increased the distance between the front and the back foot plate so that they can do a complete tarsophy, and the front plate will protrude outside the tarsophy, outside the skin. This was not successful and the results was not encouraging. The long-term survival of this type of keratosis was not good. So we are left with the two modalities, which is the modified osteo-odonto keratoprosthesis or the tibial bone keratoprosthesis. This is a cut section of the osteo-odonto keratoprosthesis. This is the optical cylinder which the patient will see through. Of course, you should remove the lens and the anterior vitreous. The eye should be covered with buccal mucous membrane. So you remove the conjunctiva and attach a buccal mucous membrane to the sclera. And here is the carrier, which is the dental lamina formed of the bone and the dentine. The dentine is considered the strongest structure in the body, after the bone, of course, but it has a very good criteria that it is avascular. The bone is vascular and may suffer from osteoporosis, but the dentine does not. So this gives the osteo-odonto keratoprosthesis a very good long-term survival rate. So this surgery is done in 2 stages, or if you want to do it in 3 stages, you can divide stage 1 into 2 stages. So the stage 1 is harvesting of the buccal mucous membrane and preparing the ocular surface, removing all the conjunctiva and the keratinized surface. Attach the buccal mucous membrane to the ocular surface. So the buccal mucous membrane is a protective mechanism instead of the conjunctiva and the corneal epithelium. It is considered can resist desiccation, dryness, any external trauma. Now, in stage 1 also, we harvest the canine and fashion the OPP lamina from the root of the canine. So this is the harvested canine. It is nearly cut into 2 halves, and this is the dentine. And then a hole is done in the dentine. Through this hole, we cement the optical cylinder and bury this complex in the infraorbital area of the other eye so that tissues can cover the bone. We leave it for 3 months before doing stage 2 procedure. So this is stage 2. This is the buccal mucous membrane. After 3 months, it is reflected. The ocular surface is exposed. Flaring is done. We do a 5 mm terrifying. Remove the opacified cornea. Avulsion of the iris. Removal of the lens intracapsular using the cryo and anterior vitrectomy. This is followed by putting the OKP lamina with the cylinder and then covering it with the buccal mucous membrane. And finally opening a hole on the optical cylinder. So this is the final appearance. Cosmetically, of course, not accepted by some patients, so this should be one of the counseling points which you should discuss with the patient. Because there are many points, but this is one important point. Many complications may arise, such as infection in the buccal mucous membrane. All these complications can be managed, but of course needs time and need patience by the patient and the doctor. You can have also bone exposure. This should be treated. The bone should be grinded and covered by buccal mucous membrane. Otherwise, infection may occur in the bone. So this procedure is not a recent procedure. This is a very old procedure, 30 years, but unfortunately it is not done except in few centers in the world. These are the centers doing them. Some of these centers stopped doing this procedure. I have 1 minute, please. This procedure was first described by Professor Falcinelli in Italy, and so to summarize, the best retention rate for all biological K-Pro is the modified Osteo-odonto. It has less incidence of glaucoma, no need for systemic immunosuppression, and it is ideal for, or it is the only solution for keratinized ocular surface and poor eyelid function. Planning a penetrating keratoplasty requires a wet blinking eye with variable limbal stem. Several treatment options have been tried with varied success in eyes not amenable to traditional cadaveric corneal transplant. OKP is considered the best modality of treatment in eyes with dry keratinized surface and limbal stem cell deficiency. This picture is 30 years old, so this is Professor Falcinelli who described the procedure of osteo-odonto keratoprosthesis. This is his son, Johnny Falcinelli. Unfortunately, he did not continue in the same field. Professor Gunther Gardner from Austria, who is now retired, and Professor Conrad Hill, and Professor Christopher Leo, who taught me this procedure, and he is still doing this procedure in the UK. So, the last slide. Okay, this is دي بقى من جورنال الاهرام سنه 2017. صدق او لا تصدق، كانوا فعلا جايبين صوره عيان one of the patients of Christopher Leo, where this patient was following up in the UK. They were stating that this patient had restored his vision through having a tooth.